Hello everyone, welcome to Pre-Hospital and Disaster Medicine podcast number 4. My name's Joe Cuthbertson. This is a production as part of the World Association of Disaster and Emergency Medicine, or WADM. And today's podcast, we're very lucky, we're talking to Dr. Greg Ciottone and his colleague in this paper, Dr. Michael Court. They've both published Counter-Terrorism Medicine, Creating a Medical Initiative Mandated by Escalating Asymmetric Attacks, recently published in Pre-Hospital Disaster Medicine. Now, Dr. Ciottone, he's the president of the World Association of Disaster Medicine and has a distinguished history as an associate professor of emergency medicine at Harvard Medical School and an instructor in the Department of Health Policy and Management at Harvard. And his colleague, Dr. Michael Court, is a UK military physician with a special interest in disaster medicine and a graduate of the European Masters in Disaster Medicine and is part of the faculty on the BIDMC Disaster Medicine Fellowship. So welcome to you both, and thank you for spending the time for this podcast.
Thanks, Joe. Appreciate you having us.
Yeah, good to be here.
Thank you. So let's start the counter-terrorism medicine, or CTM. It's very new. Can you tell us a little bit about it, Greg? Where it's come from?
Sure. Well, there's been some talk of the idea of the healthcare response to terrorism in the past, and some articles written, and there's been at least one or two books written talking about this idea of terror medicine, meaning, what's the healthcare response look like to some of these terrorist events. But one of the things that we wanted to set out to do was to see actually how much in the literature is there about this, and also does it appear to be, or is there something that's unique and different about terrorist attacks, particularly in the last 20 years or so, when we've seen a much higher degree of sophistication in some of these attacks. Prior to that, most terrorist attacks were rather linear. There would be a bombing event or some sort of event, and then that would happen, would cause the casualties, unfortunately, that it causes, and then the event typically would be over. In the last 15 to 20 years, we've seen certainly an escalation in the sophistication, right around 9/11, not necessarily starting with 9/11, but right around then and since. We've seen multimodality attacks. We've seen these asymmetric attacks, very well thought out, strategically attacking, whether it's a region, a city, whatever the attack target is, in this, again, sophisticated way. So that has made the response that much more complicated, and it's not the kind of response perhaps you can just run out the door and do without preparing for properly. So in thinking about this, we wanted to look at the literature, first of all, to see what's out there around this idea of counterterrorism medicine, and then also we wanted to establish an entity, counterterrorism medicine, that would not only help us to evaluate and figure out the best way to respond to these events, but even more importantly, to try to be proactive, I guess, versus only reactive in the mitigation and preparedness phase. So we wanted to, really see about creating something where people who look at this and practice this kind of, initiative in medicine really take a harder look at that pre-event phase, so that we can be a little bit more effective and efficient as we respond. That's my thought of this. Michael, what do you think?
Yeah, no, Greg, I think that's all really valid points. I think it's the body of work in this this area has increased significantly, as Greg has mentioned. But what we recognise is that much of this is done in silos of excellence, and that there are people working, doing some incredibly good work in areas. But what was lacking is a way of bringing this sort of together under a sort of an umbrella term, so that we can recognize the interrelationships between all of these different areas, and the impact on one another, and also therefore to be able to learn from these sort of interrelated different areas to improve that response, both the response to the recovery, as well as obviously those mitigation and preparedness activities.
Thanks, Michael. That's really given it that EM lens, or disaster medicine lens, around it. From your perspective, What's driven the need for this at this point in time? Why now has this come to the forefront in your mind as a need from a global health perspective?
Well, I think whether it's from the perspective of the WHO recognizing intentional acts of violence as a significant health concern, whether it's from the public perception of the risk of terrorism, whether it's from the growing threat to healthcare itself from acts of deliberate violence and terror, or whether it's actually from the sort of the impact that it's having, there's been a groundswell really, and that's been reflected in the literature that we've seen as well. So despite pure number of terrorist events that have taken place pre 9/11 and post 9/11 hasn't altered much, but the terrorism itself, these deliberate acts of violence that impact healthcare systems, are growing in complexity and changing on a virtually a daily basis. And we've seen that in the modality to which attacks take place. In order to counter that, one of those is having a robust process whereby we are rapidly able to learn lessons from responses and integrate that into those preparedness and mitigation activities. And I think there's recognition now, like I say, and that recognition is taking place in various different areas, be that with our surgical colleagues looking at the sort of the trauma response, EMS and tactical EMS, but particularly in those areas we're looking at trying to get to from those preparedness and mitigation, and the fact that really to have an impact there from a medical perspective, we need a seat at that table in that discussion.
Yeah, and if I were to add to that, I think also that again with the increase in sophistication of these attacks, as I mentioned before, but also these new modalities that are coming about. It seems like in the last 15 or 20 years, we've seen the advent of all these different new modalities that are being tried, some successful, some not. We've seen vehicle ramming, incidents. We've seen the risk of at least chemical weapons with all of the places that we see these chemical weapons appearing in the civilian world, whether it's the assassination attempt in Malaysia or in the UK, or now recently in Russia with some of these nerve agents, or if we're seeing in conflict areas like in Syria, the use of again sarin and or chlorine gas. These really horrible chemical weapons that were designed for the battlefield and really should never have been used there nor anywhere. Are now starting to be seen in the civilian world at a much greater rate. So that risk has to be kind of multiplied and brought into this equation. And again, these other new modalities, I think, forces us to, again, be very proactive in the way we prepare for them. As I like to teach to, the fellows in our program and students that we have in disaster medicine, unfortunately, there's some very bad people out there, yet very intelligent people. And they are thinking up these, very complicated, sophisticated, intelligent ways of attacking us. So we need to be equally intelligent in how we, prepare, mitigate, and plan to respond to these if we're going to be most effective. And some of that also includes almost modifying the way we do a hazard vulnerability analysis. There is, in your standard HVA, there is some, looking at intentionality, but if we look at it from this perspective and do almost, something I like to call an attack vulnerability analysis, you actually might identify a number of areas around you in your community that are high risk targets. And again, these are the kinds of things that a terrorist attack would try to exploit. It's that kind of soft underbelly, these high risk targets that make it that much more effective if you were to attack them. So I think for all of these different reasons, this is a good time now to start talking about creating this initiative.
Thanks, Greg. When as you've created this initiative and developed this counter-terrorism medicine speciality, the fit at the moment is within disaster medicine. What prompted that as the fit for this specialisation or this speciality, and is it the right fit going forwards?
Well, we think so, certainly. If you look at it, disaster medicine is that very unique area of medicine where it's not, we don't, as disaster medicine specialists, we don't wake up every morning and go to disaster clinic and see disaster patients, right? We do a lot of training, we do a lot of preparing, all these different phases of the disaster cycle that we participate in. Yet we may never actually encounter it in our career in some cases, and when we do encounter it, it's rare. It's these low frequency, high acuity events. However, because they're high acuity, it's almost like that airline pilot, who flies the route, every single day for 20 or 30 years and may never have an in-flight emergency at all. But the reason that we can sleep comfortably in the airplane is that we know they've trained, hundreds, if not thousands of hours, on those low frequency, high acuity events, so that if they should happen, they're ready and prepared to handle it. Very similar in disaster medicine. And then if you look at it again, this is the same way counterterrorism medicine is. Counterterrorism medicine will respond to these terrorist events, and they are, the most sudden of all disasters, I think. I mean, there are other events in disasters that can be as sudden, say an earthquake or something along those lines, an explosion. But it's that idea that you're practicing your everyday, you're doing your everyday work, and then suddenly something happens and you have to flip that switch and go into counterterrorism medicine mode. So I thought it was a natural fit, because of that. And I think when we looked at it, we said, why don't we just, suggest this as either whatever you'd like to call it, a subspecialty of disaster medicine, because of those similarities they share. Michael, what do you think?
Yeah, no, I completely echo that. And I think, for me, I think, disaster medicine is, like Greg mentioned, it's these high acuity, low frequency events. I mean, the job of the disaster medicine specialist is to go countercurrent to normal human nature, which is to assume the best, and it's to actually assume the worst and to think about the worst. And a terrorist event, for the most part, is a worst case scenario. But I think why within disaster medicine is because it's a broad church. There are multiple elements that sit within this and are stakeholders within this place. There's room at this table for for the psychiatric element and the response to both responders as well as to victims, just as there is to our tactical EMS colleagues who specialize in that initial response piece. So it's a broad church, but it needs to sit under an umbrella term. But fundamentally, for me, behind this is disaster medicine is about taking never events and learning from them and putting it into that cycle of response, recovery, mitigation and preparedness, so that what we're doing is being able to be better prepared and better able to respond to those future ones. And so it fits within that piece that we're going to learn from the previous events within that disaster cycle.
Thanks, Michael. Just out of interest, so we're at the start of maybe not at the very start of this initiative, but we've got this editorial paper that's been published that outlines how counterterrorism medicine fits within the disaster medicine framework. And you've also noted that how elements like tactical EMS require further development within the paper or further examination. In your mind, what is the end state as counterterrorism medicine starts to generate further evidence and development? Where would you like to see this progress towards?
Well, I think fundamentally, this is very much we've produced this paper really as a challenge to the academic community, and I'm hoping this podcast will be part of that, which is to say, what do people think? What should be within this? And part of that next process is going to be part of the designing of and the defining of what sits within this new initiative. But beyond that, it's a place and a home for all of those stakeholders that we previously mentioned, so that we can link up these kind of silos of excellence. So what I would like to see is I'd like to see things like a CTM or counterterrorism medicine as a mesh search term, so that we can publish under this as an umbrella term, so that when you are looking for papers, we're trying to build bodies of evidence, because it is so difficult in disaster medicine to build bodies of evidence when we're talking about these low acuity events, that we can do so more easily and create this kind of network and collegiate approach to best supporting both responders and also victims during these events.
Yeah, and if I were to add, I think that the paper was clearly written to bring awareness to this to the healthcare community. That's one of the things that we really wanted to do, so that within the healthcare community, much like, we've for the last 30 or 40 years or more tried to bring awareness of disaster medicine to the healthcare community, so that, as we say, there may be some disaster medicine specialists, scattered around the healthcare community, but because, all disasters are local, and really the first 2 to 3 days of a disaster is really almost entirely dependent on local resources. Everybody feels that all healthcare workers, everyone in medicine in whatever capacity, should know just a little bit about disaster medicine. Well, in the same sense, I think that healthcare needs to take that kind of ownership for these terrorist events, unfortunately, because they are escalating and they are becoming more sophisticated. So, the same commitment we need to make to the public that we serve to be there for disasters, we should make also to be there to provide the healthcare needs for terrorist events. But further, on the other side of the equation, also, one thing that we want to make sure in counterterrorism medicine, and I say this all the time to my students, is that we want to make sure that we stay in our lane. Okay, we are counterterrorism medicine. It is not counterterrorism. We're not the intelligence units that are searching these out and trying to prevent them. We don't carry the guns and et cetera. But we, in writing this paper, we firmly believe that healthcare deserves a seat at that counterterrorism table, because of the, again, sophistication of attacks, new modalities, all these other aspects that make it not that much more complicated to respond. So on the other side of that equation, we want the counterterrorism community to understand that healthcare is part of the team. And that we need to be at that table so we can bring up some of the mitigation preparedness steps that might be, needed or required, that maybe, others had not thought of. And plus, the old adage that we train like we fight and we fight like we train. Well, if we're going to be in this together when the event happens, we should be in this together when we're mitigating and preparing and planning. So I think, for those reasons, we want to see counterterrorism medicine kind of grow into that role in both cases, in the counterterrorism environment as well as in the healthcare community.
Yeah, and I'd echo Greg's and that's perfect. And I think the challenging questions come from that. There's two aspects here. There's the healthcare response to, response to potential terrorist threats and potential terrorism events. But there's also the healthcare as the target of terrorism events, and broadening that understanding amongst healthcare professionals of target hardening and how and the responsibility of healthcare facilities to try and make themselves less of a soft target, and what that might mean is something that is worthy of putting out there as a discussion, because by any measure the impact and certainly the appetite for attacks on healthcare facilities and healthcare workers, whilst not necessarily echoed across international terrorism, certainly in domestic terrorism settings, is definitely there.
Yeah, that's a great point, Michael. Actually, the other thing that we've seen escalating in the last 20 years is this idea of primary attacks on healthcare personnel and healthcare facilities. Prior to that, we've always been seeing some episodes of these secondary attacks where an event might happen and responders might move in, and there might be a second event aimed at the responders coming in. But unfortunately, we've seen recently this escalation in the idea of primary attacks, and that's concerning, because that falls into the idea of scene safety, and another reason why counterterrorism medicine really should sit within disaster medicine, because we think about and worry about the same things and we respond. But when you bring the aspect of is the scene hot, or am I a primary target as either a hospital or healthcare personnel, of this scheme of this terrorist attack strategy for this event, brings a whole nother layer of complication and difficulty in how it is that you protect yourself. And again, as Michael said, target harden.
Some really great points. Look, thank you so much, Greg and Mike, for your time today. I'd really recommend to our audience that you log into PDM and read the latest editorial. And if you're interested to engage in this space, it sounds like there's plenty of work to be done, and we're just at the beginning of this journey. I'm really looking forward to seeing more articles published around this practice. Greg, thank you for your time. Michael, thanks for your time. It's been a great podcast.
If I may add one quick thing too, Joe, just to give that plug plug for Wadham. There is a special interest group at Wadham in counter-terrorism medicine, and if there is interest in those who are listening to this or reading the article, please do join Wadham and join the group, and let's move this initiative forward.
That's an excellent point. Yeah, we definitely want to see some growth, and we need that engagement across health disciplines to inform us and build that body of knowledge. Michael,
Yes.
any final words or thoughts on where you'd like this to go to next?
No, not at all. No, I think you summed up perfectly well, you, Joe. It's the start of it, but this is it's a broad church. It's an open forum, and the more people we get at the table, the richer that conversation, those discussions will be. So I look forward to what's going to come out to the next few years as we develop this.
Thanks so much, Michael, and thanks to everyone listening to this podcast. We'll see you at the next event soon. Take care.
Thank you.